Thank you. I hope I can define it for you. And actually, when I review this topic, I figure, why is it important to define it? I mean, we almost can tell when someone is so sick that he's not going to make it, and we almost can always tell when someone is relatively healthy. So I'm kind of going to approach this from a very practical standpoint and answer a few questions. And the questions I pose in this slide, I think what is not end stage is relatively simple. So I will tell you in heart failure what is not end stage. I'll try to discuss with you what is clearly end stage, because those two extremes are very simple to define. And the real challenge is not in either of those two categories, but the real challenge is among those ambulatory patients that are ill, and that's really the question that perhaps you wanted me to address. But let me take this one at a time. So what is not end stage? Let me start by going over the crux of what's heart failure. Heart failure is a progressive disease. It does not stop at one single point in time. Heart failure is not pneumonia. You can get pneumonia, get treated, that's the end of it. You don't have it again. But heart failure is progressive, and what may not be end stage today may be end stage in a year. And this is highlighted by very seminal observation by Dr. Barry Greenberg and Mike Quiñones in a paper. It's an old paper from the SOLVE database that shows the change in LV mass in placebo-treated patients in the SOLVE trial, as shown in here, that it shows this progressive increase in LV mass as a paramount signature of the progressive disease, and the very powerful effect of the ACE inhibitor in this particular study of patients with left ventricular dysfunction. So heart failure is progressive, and medicines allows to hold the condition, but it doesn't really reverse it. And you can see the same in end diastolic volumes in the prevention arm and in the treatment arm of the SOLVE trials, which really represent our landmark observations in the progressive nature of that illness. So prevention, as you can see, and I want to highlight this to you, these, to remind you, SOLVE studies were patients all with left ventricular dysfunction with an LVEF less than 35%. And if they were asymptomatic, they were randomized to prevention. And if they were symptomatic, randomized to treatment. And the randomization were rather simple. Nurses call patients and they were asked a question. Would you short of breath when you walk? Can you climb upstairs? And if they say no, they go to prevention. And if they say yes, they go to treatment. And look at the difference in volume. Prevention, much less volume. And if you look at the treatment, the significant increase in volume. Both had treatment effects, but the treatment effect is greater when patients are sicker. And what I want to highlight to you is that all of these individuals have significant LV dysfunction. The presence of symptoms was associated with hearts that were sicker. Now, let's look at mortality in these two groups, and specifically, let's look at mortality in the SOLVE prevention and in the SOLVE treatment. And this is placebo mortality. The SOLVE prevention mortality at 4 years was 20%. SOLVE prevention mortality. SOLVE treatment mortality was 38%. Now, look at the EF in each of those respective groups. In the treatment group, LVEF was 25%, and the prevention group was 29%. I think this is the very, very crucial, important piece of information. In fact, I like to always highlight this to internal medicine doctors, to cardiology fellows, and to residents, because ejection fraction is not very powerful discriminator once the group of individuals have low EF, but is that capacity to adapt to those symptoms. So with indistinguishable changes in ejection fraction, the mortality doubles if you have symptoms. That's what it showed. This is 20-year-old data, but still remains very powerful. And I'd suggest to you that when we're evaluating patients for transplantation, we look at symptoms as the most important component, whether it's hospitalization, whether it's the inability to walk, or whether we can do more objective assessment looking at exercise VO2. But at the end of the day, we're trying to quantify symptomatology. And that comes from this very old observation that's very powerful. We can look at modern era mortality, and this is data for the Paradigm Heart Failure Study. And if you look at mortality here in the second, on the right side of the slide, death and cardiovascular causes, the mortality is really at over 4 years is perhaps no more than 20%. So that's consistent with this observation. The mortality in asymptomatic, even untreated patients, as in the SOLVE prevention with LV dysfunction, maybe not greater than 20%. So it is that powerful ability of the human body to adapt to a state of low EF that really defines prognosis. So if you get to see and evaluate a patient with low EF, and it's asymptomatic, he's going to do fine or she's going to do fine, that clearly is not end stage. So low EF does not define stage. And I know I'm repeating these over and over, but I have to tell you that a very, very common source of consultation in our hospital is low EF. And people don't know how to do with it. And I tell you over and over again, low EF in asymptomatic patient, very good prognosis. And you can modulate and you can do very fancy analysis and plot it in models that are very complex. And you can do this as a reference to the Seattle heart failure model. You can plug in a lot of variables and have predictive assessments of mortality. And I know Wayne Levy is trying to come up with an application so that you can download in your phone, enter the variables, and give you an estimated prediction of mortality. So clearly not end stage or asymptomatic patients with low EF. It almost doesn't matter what the EF is. Now let's see what's clearly end stage. What population of patients we looked at and we say these people are not going to make it, we either need to go to transplantation or go to an LVAD. Well, I say perhaps one of the most powerful pieces of information comes from this trial, which we've referred to it multiple times before in this meeting, is the rematch trial. And let's look at this curve in white, which is the optimal medical therapy branch of the rematch protocol. And if you can look at this study, patients were predominantly, most of these were on inotropes. They were inotrope dependent. And the 1 year mortality is about 75%. And by 2 years, almost everybody has died. So if you are so sick that you have so much symptomatology that you require an inotropic agent, your mortality is 75%. So there is no more end stage than that. And then you have to make decisions whether or not you accept that and go to palliation, or whether you want to go to VAD, or you want to go to transplantation. So anyone that has severe symptomatology that requires inotropic agent, it's end stage. That's also very simple. So LV dysfunction asymptomatic, easy. Very symptomatic, need of inotropes, also very easy, because the mortality is very high. So this population, I only depicted here that, but you go to transplant or you go to palliation, and that's a perfectly nice, a simple way to assess that population. Now this is the challenge, and the challenge is perhaps what the majority of the patients that we face will be, which are those high-risk ambulatory patients. How do you tell them apart? How do you decide someone who has low EF, has some symptoms, who may be in and out of the hospital sometime, who among those really requires aggressive intervention? So I remind you that every time we do an aggressive intervention, the risk that the patient will ensue is much greater. So how do we go about trying to look at those patients? Well, in this meeting, we've also looked multiple times at this classification, the INERMAX classification, and we've looked at advanced treatments for heart failure. And it is clear that as you get sick, the prognosis is poor. So INERMAX is a classification shown in here, where most of these patients are class 3, B, and 4. So those that are 1, 2, and 3, very simple end stage, very sick patients, multi-organ system failure, the stable inotrope therapy. But then if you go INERMAX 4 to 7, those are patients with recurrent advanced heart failure, restant symptoms at home. Some of those that have exercise intolerant, they may be ambulatory class 4, limited exercise capacity, walking wounded, somebody that's tired, walks around, maybe cannot climb upstairs, advanced class 3. So between INERMAX 4 to 7 is challenging. You may say 4 is simple. Maybe 5 and 6 is hard to do. So these are perhaps those individuals where defining end stage is difficult. Now, why is it important to define who's end stage? Because if you're saying end stage, you're defining, at least subjectively, a very high 1 year mortality, where interventions will be VAD, transplantation, or a decision to do just palliative therapy. So let me go a little bit on some of those data. Now, this is a study Dr. East, my colleague, presented to you earlier, and this is the optimum medical managed mortality of the roadmap trial. And you can see here the LVAD-treated population in this chart in red, and the, I'm sorry, in red is the medical treatment arm, and in green is the LVAD-treated group. In the roadmap trial, patients were randomized that were 4, 5, and 6. And in this cohort, complex cohort, it shows that there is a benefit, and the benefit is highlighted here, but perhaps that benefit of mortality may not be that great that people will accept this strategy overall, although statistically significant. But as you can see, in those patients that were on an LVAD, 80% survival at a year, 65% survival with optimum medical therapy. Statistically significant. That there is a price to pay to be on a VAD, and in this study, Jerry and his colleagues demonstrated a clinical significant benefit. Whether or not that benefit is going to be extrapolated to larger populations is something that we have to see. But the difference is not as great as showing a mortality benefit when the mortality is 75%, and you can provide someone with a 25% mortality. And that's where the difficulty resides in terms of defining who is end stage. End stage will allow us to define an individual where the risk of mortality is so high that you're willing to take the risk of an intervention that always poses some significant risk. So you can look at a variety of markers to try to dissect further end stage. You can do serological markers, so biomarkers. Catecholamine have been around for a long time. BNP levels, sodium, hemoglobin, uric acid, and there are a number of other biomarkers that we can study. It's really difficult to pinpoint one particular biomarker and decide that that will be a discriminator to decide what patient is going to be end stage or not. But again, functional assessment, the ability of the patient to adapt to a state of poor pumping function, can be also objectively defined by peak VO2. This is a paper published in the European Heart Journal years ago by Stefan Anker and Andy Coates, and it shows different gradients of peak VO2, as you can see here in this slide. And importantly, the lower the VO2 in that population, the lower the survival. The higher the peak VO2, the higher the survival. And this has been used for many, many years in cardiac transplantation programs to define ambulatory patients at high risk of death, where we can decide that someone who has a very low peak VO2, typically a peak VO2 less than 10, has high mortality, defining end stage, therefore a decision to move to transplantation or to VAD therapy. Now, in the same paper by Stefan, they also look at the relationship between the increased ventilation per carbon dioxide production, that the VCO2, and it provides increment of value, and the observation is the same. Those people with poor exercise capacity can be subdivided by looking at peak VO2 or VCO2, and you can establish very powerful prognostic indicators based on those observations. Now, I think that on a clinical daily routine in our practice, we looked at other parameters that are very powerful and important. When we're trying to decide an ambulatory patient for more definitive therapies, we like to see the impact of this state of dysfunction in other organs. And we just went through the session looking at the impact in pulmonary hypertension and the powerful discriminatory survival advantage of every function. Pulmonary hypertension is a very important organ, or pulmonary hypertension is a very important marker of disease progression, and if you perceive that the illness will progress to develop significant fixed pulmonary hypertension, that should be a discriminator. Liver fibrosis and cirrhosis and renal failure. So let me walk you through brief pieces of data in each one of these organs. So I'm not going to spend too much time because we just reviewed pulmonary hypertension in depth, but suffice is to tell you that when you have post-capillary fixed pulmonary arterial hypertension, the probability of undergo therapies that are long-lasting and life-saving is significantly reduced. People with fixed pulmonary hypertension are not candidates for orthotopic heart transplantation because when you put in a new organ, the fixed pulmonary hypertension will cause invariably RV failure. So if you have a patient with advanced heart failure that has postcapillary pulmonary hypertension that's fixed or that's becoming fixed, that should be a discriminator to define that patient as end stage so that you can take a very aggressive route to try to prevent progressive organ dysfunction. So how do we go about that? We just, again, and I repeat this data that we just saw in the previous lecture, you can look at diastolic pulmonary gradient as perhaps one of the most exquisite markers today, and a DPG more than 7 and a PVR more than 3 defines that population. And if they are reversible, you can work with them. If they are fixed, you may need to institute therapies long-term. Chronic mechanical unloading perhaps may induce reversibility of this condition. So we have looked at this condition of fixed pulmonary hypertension, and again, the importance is that if patients are approximating this condition, you have to intervene before they are fixed. And that defines a crucial moment where you can define an ambulatory patient high risk as someone who's becoming end stage. Now, the liver is another very important organ, and just like we focus on the lung, the liver is also a bystander of the hemodynamic disarray that occurs in patients with advanced heart failure. And when you have evidence of increased portal pressure as defined by here, a portal pressure more than 6 millimeters of mercury, and particularly more than 10 millimeters of mercury, when you see that gradient changing by that also, just like in the case of the lung, that also defined intrinsic portal hypertension that may lead to fibrosis and then eventually cirrhosis, which may be another defining moment for the end stage condition in the liver. So you clearly do not want to get patients to get to that level. You should think about the liver just like the lung, and the passive congestion of the liver may lead to intrinsic portal hypertension, and that gradient of more than 6 or more than 10 specifically defines a condition that may be irreversible. You want to monitor patients and to try to tackle them before they get to that point. Because once they get to that point, clearly it's not only the heart the problem, but the heart and the liver. And not infrequently, we see more patients that develop fixed pulmonary hypertension, and more over the last, say, 10 or 15 years, we see more people that have concomitant liver disease with heart disease, and perhaps this is the result of very aggressive medical therapy that allows to maintain people living longer with hemodynamic decompensation, pulmonary hypertension, passive congestion of the liver. And in our program, we have an experience with a number of patients that have successfully undergo heart and liver transplantation because of this condition. So we have to identify these high-risk ambulatory patients before they develop significant liver disease. So let me, in the last couple of minutes, just talked about the cardiorenal syndrome, because it's perhaps one of those that we looked in more detail. So I've looked, and I share with you very simple observations on how the lung can be passively injured, the liver can be passively injured, and of course we all face and are more in tune with cardiorenal syndrome as another organ that's affected by the severity of the cardiomyopathy. And I'd like to highlight to you perhaps these different categories. This is actually a very nice slide that I've obtained from UPenn. But you can look at this category where I see no pump. And this is a condition when the patient may be weathered normal, where the cardiac output is very low, the SVR may be normal, they may not have any proteinuria. And the treatment of this is very advanced cardiac support. You need more pump. Once you define renal dysfunction as a consequence of poor pump, and these may be the features to define that, I suggest to you that it is the time also to define this cardiac dysfunction as or the cardiac syndrome of the patient as end stage. That may be another discriminator for that condition. So let me summarize this talk by saying ambulatory low EF, they'll live long. These people will not have a problem. Critically ill, in need of inotropes, very poor prognosis, clearly end stage. Ambulatory high risk, those that have functional objective data of severe limitation of function, like as defined by the peak VO2 or VVCO2, and those that have evidence of end organ dysfunction as determined by markers of pulmonary hypertension, portal hypertension, or renal dysfunction. I think ongoing registries will further help us define this condition. Thank you for your attention.
Thank you.